Dear colleagues, this is a case of a hypermature cataract. I'm usually cleaning up the conjunctiva and conjunctival bags with betadine before starting the case, making two paracentesis. This is a very small, shallow anterior chamber. Patient had glaucoma also. Placing some viscoelastic inside the bag to press down the anterior capsule, and I'm fashioning the capsulorhexis using 27 gauge end gripping. This is a vitreoretinal forceps, and with this capsule that was stained with trypan blue, it's very easy to watch the capsulorhexis edge where it's going. In this section I try to run out, but I easily pull towards the end, the center, and closing the capsulorhexis. This is a fluffy cortex, but the nucleus is very leathery, thick one, and I'm usually trying to do a small pit close to the middle of the nucleus in order to be able to bury the phaco needle with the sleeve inside that pit and be able to crack the nucleus with horizontal chop. I'm insisting to crack until the last part of the nucleus, the back plate, and rotating 180 degrees, and propagate that crack all the way down on the other side also. This way I have two separate heminucleus. Doing the horizontal chop without engaging the foot pedal, just on irrigation, no vacuum, no ultrasound, holding the nucleus, and then with the chopper going across, mechanically divided that half of the nucleus into two quarters. Again, further and further division of the nucleus. I'm trying to keeping the phacoemulsification inside the bag. The bevel down position of this phaco needle, or making a little bit on the lateral side, it's helping me achieve the phacoemulsification inside the anterior, the bag, not the anterior chamber. So in this way, keeping the ultrasound far away from the cornea will get you a clear cornea the next day. The nucleus is kind of leathery, so I'm using the chopper a lot to do smaller chops, and be able to use more vacuum than ultrasound. So this will help out the healing of the eye post-op. Getting to the last heminucleus, the other half of the nucleus, and further dividing and chopping in smaller pieces this leathery nucleus, moving the pieces around inside the bag using the phaco probe irrigation and the chopper. It's bringing the pieces centrally. The pupil is kind of getting down, and losing the iris is losing the dilatation, but it's all good. It's the last part of phacoemulsification, This is very important to not rush through this segment, since the posterior capsule is very, very close and exposed. I'm leaving this small piece of epinucleus to be washed out by the irrigation from the needle, and then using the aspiration needle I'm pressing down the iris root to break the anterior synechia. In this way the patient will have a lower IOP post-op. The trap will filtrate the aqueous humor better post-op, and glaucoma medication will go down. Trying to clean up the last remnants of cortex, and cleaning up the bag, polishing the posterior capsule also with this sandblasted aspiration needle tips, and that's getting good outcome. The next day the patient will see very well. Injecting the IOL inside the bag using the Aurocert system, and then placing the trailing haptic inside the bag using the irrigation cannula, and injecting the myocol and air bubble at the end, and that's pretty much the whole case. Thank you for your attention. Hope this will help you in your practice also.